Welcome to this AARC interview with Dr. Michael Anderson. Our focus today is to discuss the issues facing respiratory therapists as they work on the front lines and caring for their patients both with COVID-19 and, of course, those without COVID-19.
Good day.
Michael Anderson is our guest today. Dr. Anderson was named President of UCSF Benioff Children's Hospitals and Senior Vice President of Children's Services for UCSF Health in December of 2016. Dr. Anderson is an authority on children's health policy, pediatric disaster preparedness, system quality, and physician workforce. As President George W. Bush's appointee, he served as Vice Chair of the National Commission on Children and Disasters. He has testified before the U.S. Senate and the President's Commission on Bioethics. He has chaired an Institute of Medicine Committee on Pediatric Disaster Response and Recovery, and is a consultant to the CDC and the U.S. Department of Health and Human Services National Disaster Medical System. In 2014, Dr. Anderson was appointed by the Obama administration to chair the National Advisory Committee on Children and Disasters at HHS. He has served on 3 national committees for the American Academy of Pediatrics and chaired its Committee on Pediatric Workforce. Dr. Anderson is also a friend of the AARC and a supporter of respiratory therapists. Thank you so much, Dr. Anderson. We know there are competing demands on your time, and we are very appreciative of the fact that you can spend some time with us today to answer a few questions that are really important to respiratory therapists.
You know, it's really my pleasure to be here. And when the AARC called, I jumped at the chance. Number one, I am a fan. Respiratory therapy, number one, has saved me numerous times as a pediatric intensive care physician. I've learned so much from respiratory therapists, and I'm just honored to be here. You've seen a lot in the press about sort of the new American heroes, the front line of healthcare workers. But if there's any healthcare worker that is the front line, thinking about ventilators and aerosol precautions and infectious patients, respiratory therapists are literally the tip of the spear. So I'm just honored to be here to talk about this incredible time we're seeing right now.
Wonderful. And this is an incredible time. This is unprecedented. Those of us who have been in the field for a while have lived through H1N1. We've lived through big flu seasons. Those of us in pediatrics recall the days of ribavirin and RSV. And so here we are today with SARS-CoV-2. Just to get everybody on the same page, can you give us just a brief summary of SARS-CoV-2 and this concept of flattening the curve?
Yeah, this is scary. And I know, you don't want to panic. We as healthcare professionals don't want to panic, but we do want to be honest with people. There's a couple of really concerning things about this virus. Number one, it is truly novel. We haven't seen it before. So nobody in the world, except for those obviously who've been infected now, have any immunity to it. So it's not like it's a different substrain of the flu. This is novel, so we haven't seen it. Number two, it appears to be much more contagious, or people are much more contagious, an R0 number of 2, which means a patient who has the virus typically is going to infect 2. So just think about the math models. This is a very contagious disease. And number 3, and the pathophysiology of this disease is really being ramped up. There appears to be a predilection for this novel virus to really attach to alveoli and small airways. Once again, a lot of pathophysiology being worked out. So this is novel, this is new, and it's really interesting in this time of social media and the internet, where we typically wait for double-blind randomized placebo-controlled trials in the New England Journal. Right now, thanks to the internet, thanks to Twitter and social media, we're taking experiences from across the world and sort of, building the plane as we fly it. So that's number one. Number two, the curve you have up here, I'm really calling flattening the curve, is important. The reason that so many people are in, quarantine or lockdown right now is that R0 number being 2, meaning if I'm infectious but asymptomatic, I unknowingly infect 2 people. Well, the only way to decrease that spread is to keep people apart. Social distancing, and quite frankly, if you don't have to be in groups of people, don't be in groups of people. It does not necessarily mean that that's going to decrease the total number of people. You'll look on that curve. The area under the curve is probably similar, but the peak that we're going to see in the healthcare system, we can delay it. So the healthcare systems, hopefully, if we do this well, are not going to be overwhelmed. So that's the whole thing about flattening the curve.
So one of the things that we were talking about has involved the different types of activities that respiratory therapists do and aerosolization and such. And we'll talk a little bit more about that in a minute. But we're encouraging people to use airborne infectious isolation precautions, but we've heard that this is a droplet infection. So why, you know, the N92 masks and the goggles and all this stuff, why are we so focused on aerosolized infectious measures for a droplet precaution issue?
It's a really strange equation we're seeing right now. First, droplets really important, right? Let's do the basics of good droplet precautions. But I am also concerned that respiratory therapists, because we're giving nebulized medications, because we're changing, you all are changing equipment, because if you don't have an inline suction and somebody's on mechanical ventilation, you're exposing the room and yourself to aerosolize potential virus. I think this whole notion of trying as best we can to practice airborne precautions, even though this may not be the classic airborne virus, is really important. The thing that's so disconcerting, and once again, not in panic mode, but in transparency mode, supply chain is one of the biggest things that we are concerned about right now. It would be great if everybody could N95 and goggle and mat and do the whole thing. But right now I'm on no less than 5 HICS calls a day for Benioff Children's Hospitals and for UCSF. This notion of supply chain and trying to figure out what is the safest way to practice is really evolving. So for the respiratory therapists on this web chat or this seminar today, we do want to make sure that they are protected when aerosolized, potentially infectious patients are being cared for by them. We also have to match up, what does your hospital have? What's the supplies? And I do think, at least in our HICS command structure, hearing from the frontline staff, what are we concerned about? How do we push out latest CDC guidance? How do we not panic? Because I just want to take a slightly sensitive issue and address it. There's a lot of people either taking masks or taking gowns or taking stuff because they think that they need to be protected. This is not the time for mass hysteria and hoarding stuff. Respiratory therapists and nurses and physicians, the frontline people, really need this PPE. So I think hospitals really have to conserve. So to summarize, it is droplet, but I worry about respiratory therapy professionals being exposed to aerosolized virus. Once again, I talked about how infectious or contagious this agent is. So I think using extreme caution is really called for.
So speaking about those aerosols, then, as you mentioned, things like nebulizing medications, artificial airway suctioning, and bronchoscopy have been specifically called out by the CDC for as an aerosol generating procedure. What we're learning from our friends over in Italy and China as they have battled these critically ill patients, first off, high flow nasal cannula and non-invasive ventilation have been proposed as options to mechanical ventilation, but those are also potentially aerosol generating procedures.
Right.
And the Italians haven't seen a whole lot of help from either one of those modalities in the seriously ill patient. So do you think that high flow nasal cannula and non-invasive ventilation are things we need to put on the back burner for a little while for this patient specifically? Is that something that we simply need to use for our non-COVID-19 critically ill patients to free up some ventilators? What are some options there?
It's a really tough question because I'm a pediatric intensivist, right? So, I mean, this is the bastion of taking care of RSV and flu. And just, you know, obviously everybody watching this realizes it's been a really bad flu season for kids. So we got kids on high flow nasal cannulas all over the place. And the interesting thing, we'll talk a little bit about kids later, although kids appear to be carriers, so far the data is, with rare exception, kids don't seem to get critically ill or really sick from this. So it's difficult for me to say the following because high flow nasal cannula and nebulized medications is part of who I am. as an intensivist. But to my initial point of we're learning and building this airplane as we fly it, the whole notion of non-invasive ventilation, of high flow nasal cannula to maybe stave off somebody from having to be intubated makes sense from let's conserve resources, let's only put people on mechanical ventilation. I don't want to say as a last resort, but sort of as a tiered approach. This notion that the other countries are saying it really doesn't help much, and it may expose the room, the care providers to more aerosolized virus. I think if an institution, first of all, the physician, nurse, and therapist have to make the individual, very difficult decision in front of them. Should we just intubate this patient? And as this ramps up, the whole notion of crisis standards of care starts to come in, which is ethically really challenging. I would say, as we're seeing the data, and this is just one intensivist opinion, I think if you see somebody crumping that looks like they're heading to require mechanical ventilation, probably earlier institution of that as opposed to these non-invasive ventilation is probably important. This will all change in the moment, because what's your supply of ventilators? What's the demand of patients coming in? And quite frankly, although there may be risk that you're aerosolizing stuff, if you're running out of regular, quote unquote, regular ventilators and need to try non-invasive ventilation, that may be the corner that we're backed into. So it's a really challenging time to figure out the care for that individual patient.
So let's continue the conversation about kiddos. We started hearing that the high risk group for COVID-19 were persons over 60. And then we started hearing, well, we're seeing COVID in the 40 and 50-year-olds, but it's not as severe. And then we start hearing, well, wait a minute, now there are some 20-year-olds on ventilators.
Yeah.
So what about children? What do we need to know and deal with regarding the pediatric population?
Yeah, so far the data from Asia and from Europe is, once again, kids are probably carriers. So this notion of social distancing and keeping kids home, I think is the right move. I think if your school system hasn't closed for summer, I think that's wrong, quite frankly. So kids appear to be carriers. So thus, a kid around an elderly adult makes a lot of people nervous because that child could be asymptomatic or mildly symptomatic and be a carrier. So far in the children's hospital space, there are case reports of a couple of kids, a couple of critically ill kids, but the percentage of older folks needing mechanical ventilation is just so much higher. This doesn't seem to be a pediatric disease. However, I run a beautiful children's hospital here in San Francisco and Oakland. We are taking this seriously because we want to, and we'll talk about it in a second, we want to decrease the number of elective procedures so we don't have a lot of people coming in to the institution. We want to conserve space and stuff and supplies and our workforce so that if this ramps up, we can make some very interesting decisions like, do we take 22-year-olds? Do we take 25-year-olds in the children's hospital so that the adult hospital can take care of more of older people? So it's not even a silver lining because this is a very trying time for our world. It does not appear, unlike H1N1, where kids were primarily a target, it does not appear so far to be a pediatric disease. I don't think that lets us off the hook as children's healthcare. We've got to remain vigilant, and quite frankly, we also have to help our adult colleagues figure out how we're going to manage the next couple of months.
So let's go on to those outpatient services. A lot of our respiratory therapists work in pulmonary rehabilitation and pulmonary function laboratories and work in outpatient clinics to see persons with chronic pulmonary diseases. And at first we started hearing about, well, we're just going to screen our patients before they came in. And then as time went on, now it was, well, maybe we're only going to do certain types of pulmonary function tests or whatever. Do we have any recommendation for these types of services?
Yeah, so what we've done at Benioff Children's Hospitals, and this is a really tough one. This is sort of coming up with guidelines in the middle of this. And we've shared this with folks at CMS in Washington. I think it applies in general to outpatient, inpatient surgical procedures, et cetera. We have lumped visits into three categories. Number one is it's got to happen, right? This child has a tumor compressing his spinal cord and we've got to do this surgery. It's happening. We're going to take all the precautions we can, but that child needs the service, or they're admitted from the emergency room with some acute deterioration. The second quote unquote bucket is we've got a patient who probably doesn't need this now, An example being a video EEG visit to maybe adjust medications, or something that we can continue with the clinicians to assess, can this be delayed? And we're sort of using a 2 to 4 week delay to think about it. And the third is, this is elective. This is an umbilical hernia or something that's just, it's going to happen, but let's take our time. I think administration of each hospital, in conjunction with the clinicians, the nurses, the doctors, and the support staff, have to lump patients into those three. If an adult patient really needs this pulmonary rehab, or we know they're going to deteriorate and need an intensive care bed in a couple of weeks, well, then I think you've got to make the call that that visit should happen. If it's purely elective, it's a PFT, which is follow-up from something, then they may be in that second or third bucket. So these are tough decisions, because you're weighing the risk of not doing something, avoid or delaying care with, but what if this patient comes to our institution and he or she is unknowingly infected with novel coronavirus 19. So I think that those three buckets are what's working for us. The American College of Surgeons has come up with a slightly different triage cascade, but those three just make sense to us in the children's world.
So one of the comments that our respiratory therapists have looked into, one of the constructs that our respiratory therapists have looked into is providing these services, with the exception of pulmonary functions, which would be difficult, providing a lot of outpatient services via telehealth and some sort of remote monitoring system.
Yeah, I'm so glad you brought that up. Telehealth, I think, it's already been starting to expand. Quite frankly, we've been offering tele-behavioral health for a while, or consulting with rural emergency departments about a sick child. So we've, in the children's space, been ramping up telehealth. It's now gone exponentially, where even if you think you should be tested for COVID-19, we're trying to get people on a televisit just to screen symptoms so they're not coming to us. So the good news is, I think there is infrastructure, there is a knowledge of how to do this. This isn't de novo trying to come up with something. The interesting challenge is, in addition to everybody working from home, or a lot of people working from home, the strain on the internet. We're on Zoom right now, which thank God is working well. But these video conference, bandwidths are not endless. So I think respiratory therapists being engaged and involved in designing and implementing, we're not talking about 2 weeks from now, right? We're talking about today, of trying to engage families in these visits. CMS has put out new rules that we don't want to do away with privacy concerns, but the fact that now you can start to use things like FaceTime and other more sort of public-facing conference tools is really important. So I think the use of video is really important. I do think when the dust clears and we're going to get through this, this is going to be an incredible wake-up call. We won't even talk about the economy, because I am so far from an expert on that. I think one of the lessons learned is, how can we leverage technology better to keep people healthy? We're going to learn a lot of lessons from this. As a disaster advocate, I think there's going to be reams and reams of things we can do better going forward. But I think the use of telehealth is terrifically important. And now I jinxed us because I can't hear you.
I'm sorry, I had myself on mute.
Oh, I was worried about Zoom. Good.
No, you just said Zoom is doing great, and here I was trying to jinx it.
Yeah, that's why I thought I jinxed us. Yeah.
So let's switch over to an acute care model. We know that we're going to get a surge of patients. We're planning for what we're going to do with all of these mechanically ventilated patients, and we'll put the equipment for mechanical ventilation on hold for just a second, and we'll talk more about staffing. Yeah. So the SCCM proposed, and this is not new, this has been out with, just for our listeners, this is not a new concept. SCCM had proposed this quite some time ago. This has been floating around for a while. A tiered staffing model for pandemics. So as you're looking at this, I'm going to move some of my notes here away. As we're looking at this, we can see that the intensive care trained physician would be over a great number of people. Mm-hmm. And then there are some non-ICU physicians who would take ownership of some teams. And that second layer of each teams includes the respiratory therapist, the CRNA, an advanced practice provider, and then that third tier contains nurses, and then the non-ICU nurse or APP at the bottom over a great number of patients. And I think that a lot of folks who have seen this have said, whoa, wait a minute, what do you mean I'm going to have to delegate some of my mechanical ventilation work to non-respiratory therapists? What do you, number one, can you talk a little bit more about how this potential model could work, and then
Yeah.
what would be required of the respiratory therapist in this situation?
Yeah, let me take the plane to 30,000 feet for just a second. So this is, I think, a terrific example of something called crisis standards of care. You would never implement this model during normal business in the winter of 2020, right? That we have our staff. I'm a PICU doc, right? It's 4 residents, 2 med students, an attending, a fellow, and 4 respiratory therapists, and probably a 1-to-2 or 1-to-1, nurse to patient ratio. This is completely different. So I will send you what I think is a fascinating article just put out by the ASPR, the Assistant Secretary for Preparedness and Response. It's a refresh of how do we think about crisis standards of care. I think people instantaneously go to, well, we're triaging whether somebody gets a ventilator or not, and those are going to be really tough. Oh yeah, those are really tough. But now at 10,000 feet, these are the kind of things that we have been talking about for a while. And now we actually may have to implement, just because it's staff and it's space and it's stuff. Those are really the 3 S's of how we are going to respond to this. And this is the staff part for the most part. It's saying, look, if the number of patients starts to overwhelm the team, we've got to reconfigure how we do this. And healthcare workers are on the front lines, and we already know from across the world that healthcare workers are getting sick, that what if our workforce starts to deteriorate? It used to have 5 RTs on the shift, and now you're down to 3. Well, we still got to take care of patients. How are we going to do it? So at 10,000 feet, I think this from the SCCM is a good example of how do we start to do it. And then in the trenches, right now, give you one interesting example of the non-fully certified respiratory therapist. We've sent almost all the students at UCSF home, right? We've said to occupational therapy students and nursing students, some med students, there's some other ones that are staying. Right now, we just got to have the people that are fully certified doing this. And I think a lot of respiratory therapy schools are unfortunately probably in the same regard. If we start to implement this interesting pyramid approach where an intensive care doctor is now guiding teams of people and doing just-in-time training, I think it's then incumbent upon the respiratory therapy world to say, okay, who do I bring in and show just the basics of, I can supervise 10 people, 20 people on the ventilator if I've got 5 people below me. So it's a little mind-numbing when you first look at it, because it says, well, no, that's not what I've been doing for 20 years. I can, one of my favorite respiratory therapists used to say, we are breath sculptors, right? We are the people that really bring incredible art and science to this. Having said that, this is, I don't want to quote that this is a wartime thing, but we're at a time when we have to think about innovative models. And thanks to SCCM and the ASPR and all the people that have been thinking about this, we don't have to start from scratch. We don't have to just put this on a napkin and make it happen. We've got models to say, okay, how can we go to the top of license, but also how can we go to really and get as many healthcare people into this space as possible? And I think this is a great example.
I'm on mute again. I know that this is, it's very, very different. And the ethical concept of a reverse triage is something that is almost aberrant to healthcare professionals. We're in this job to save people. And so as we get further into these bigger ethical problems, we're going to see I believe we're going to see a lot of respiratory therapists really struggling with how they can provide good care to patients. The care is going to be very, very different in this situation. In the massive surge that we're talking about, the care is going to be very different than, like you said, what we've been doing for the last 20 years.
You're right. And I think that we won't spend a lot of time on it because it's outside my expertise, but it's certainly a part of my heart. This is a marathon, not a sprint. We've got to make sure that we're taking care of each other, that this whole notion of resilience, that we're living it. Here at UCSF, it's fascinating. We've got wonderful donors that aren't healthcare professionals that typically donate to help us stand up a new cardiac center or put up a new building. And what we're trying to do right now is figure out, yeah, we probably need money for stuff and things, but how can we make sure that we're supporting each other at this time? When I trained in the 80s and 90s, it was just suck it up and let's keep going and charging forth. That's not going to fly. That doesn't fly in modern medicine, quite frankly. That's not going to fly now. So making sure we're checking in on each other, making sure we're leaning on each other, because these ethical decisions, if we get to the point of who needs a ventilator and who doesn't, there's no good news, but the slightly good news is people have been thinking about this for a while. So there are guidelines from the CDC. You mentioned an Institute of Medicine panel. I've been on a couple that has started to put out, yeah, these are really tough decisions, but, and I'll be hypothetical. If you've got a 92-year-old with end-stage cancer versus a healthy 42-year-old with 3 kids, gosh, we're not just talking about these in ethics class now, right? We may actually
Right.
have to be doing it. So our ability to support each other, to make decisions together, I think is going to be really important in the next 8 weeks.
Well, let's close out our interview, because I know you are pressed for time, by talking about the supply chain, which is really, really
Yeah.
challenging. We're getting a lot of phone calls from respiratory therapists, from the news media,
Yeah.
asking us about PPE and ventilators.
Yep.
As many of our listeners might know, the Strategic National Stockpile does have some ventilators. They are the 3 ventilators that are shown on the screen here. To deploy those, the state Department of Health has to be in contact with the healthcare facilities. They have to be aware of what need arises, and then they're in contact with the ASPR team and DHHS to request those, and then there's a deployment strategy and so forth. I get a lot of phone calls from folks who ask me, how can I pick up the phone and call for these? And the short
Yeah.
answer is you can't. There's a very specific process for this. But from a facilities perspective, I'm reading on Twitter a lot of facilities that are running out of N95s and PAPRs and various PPE, and then of course ventilators are becoming hard to come by.
Yeah.
Can you explain to us from an administrative perspective how we deal with these?
Yeah, so that's a great question. And I think as you look at the HIC structure, our HIC structure has been Hospital Incident Command System for abbreviations. Our HIC structure at UCSF has been up for weeks. And we have been dealing anywhere between how do we screen employees to what do we do with visitors, and supply chain is at the top of the agenda every time. So the people that are in charge of logistics and supply chain are really our go-to people. How are we enforcing the guidelines on how people should use PPE? And then the most important officer, one of the most important people at the HICS table, is what I call the liaison officer. You're right. There's no toll-free number to say 1-800-SNS. Give me an LTV 1200. But the liaison officer should and needs to be in touch up the chain, because Health and Human Services and the ASPR office. And by the way, just one small political comment. There's really great people at the CDC and the ASPR office that are firing on all cylinders. And when history writes the book on what happened, yeah, there's some missteps. But I personally and professionally have such enormous respect for the people that are really trying their hardest to help with this, political talk aside. I think the liaison officer has to be in touch with your local government officials, has to be in touch with the local ASPR coordinator. County health departments are really feeling the strain as well, because they've been underfunded and understaffed for a long time, but they're really rising to the occasion. So this is probably oversimplifying it, but I do think a liaison officer in your facility is so important to help say, this is our need. Where can we get the supply? And I know that people are working hard. They're talking about auto factories stopping making cars and making ventilators. I never thought I would say that in a sentence, but I do think your facility, while taking care of patients, really needs to be on the horn as much as possible to coordinate this with the county, the state, and the feds, because this is going to become more serious over the next 8 weeks. I don't think there's any way to candy coat it. Muted.
I should have put the link on the page, but respiratory therapists have been trained with these machines through the AARC's SNS workshops for, gosh, longer than I've been at the AARC. And we do have a website that has just-in-time training on all 3 of these ventilators for anyone who wants to go and watch that.
That's great.
When I post the video, I'll make sure to put that link out there.
Wonderful.
And yeah, I totally agree. The folks at ASPR we work with have been outstanding, answering our questions, giving us proper information to send out to respiratory therapists. And I know that their days are very, very long indeed right now. Well,
sleep is for the weak.
Well, Dr. Anderson, thank you so much for joining us. This information has been outstanding and very helpful. I'm really excited to share this with respiratory therapists. And until I put myself on a camera, I didn't know how many times I actually touch my face. So I promise I have my alcohol-based sanitizer right here. I promise I have mine. I promise I'm being safe. And
I got called out. We're running 2 town hall meetings a week, and I got called out for how many times I did the same thing. So
I don't want somebody taking this video and using it as an example of what not to do.
Agreed.
So to all of our respiratory therapists out there, thank you for everything that you do for our team, our students, our profession, and most importantly, our patients and our communities. You are important and you are appreciated, and we see you. Thank you all so much. Thank you, Dr. Anderson.